This recording will go over cardiac disorders for pediatrics. First up is congenital heart disease, an anatomic abnormality present at birth that can lead to congenital heart disease. So anatomic abnormality present at birth. So the patient is born with something wrong with the anatomy of the heart. Because of that, blood doesn't flow like it normally should. These structural abnormalities lead to altered blood flow. So the problem isn't always the heart muscle, but how blood is moving or isn't moving. This is a good time to review your basic anatomy of the heart as well as blood flow. So if you're still feeling rusty on that, knowing the different chambers and valves and how blood flows through the heart to the lungs, back to the heart and to the body, you got to have it mastered. So take some time to review that content. One thing you'll see with anatomical abnormalities of the heart, or not actually see, it's something that you'll hear, is a murmur. So you probably have heard the term murmur before. It's an abnormal heart sound caused by turbulent blood flow. So if blood is flowing smoothly through vessels and through the hearts, you don't hear it flowing. But if it's turbulent because it's going through holes or narrow valves or going through wrong pathways, you'll hear sort of a swooshing sound that's known as a murmur. So what I'd recommend you do is pause the video now and go search a video on YouTube that lets you listen to a murmur just so you can hear what it sounds like. The first defects that we're going to talk about are defects that increase pulmonary blood flow. So defects that increase blood flow to the lungs. They're also known as left to right shunting, because blood from the left side of the heart goes to the right side of the heart, and then the right side of the heart pumps that blood to the lungs. So blood is pushed from the left to the right and then to the lungs, and there's too much blood in the lungs. Think that the lungs are getting flooded. Some different types of left to right shunting or defects that increase pulmonary blood flow includes ventricular septal defect, atrial septal defect, and patent ductus arteriosus. We'll focus on the ventricular septal defect and not as much on the atrial, but they're very similar. The septum is the divider between the right and left side of the heart, and if we have a septal defect, that means there's a hole. So the right and left side of the heart could share blood. When there is a hole between the two ventricles, the left and the right ventricle, blood will flow from the left ventricle, which is the high pressure ventricle, to the right ventricle. So when the heart squeezes, look, you can even see it here. It has more muscle here. It squeezes and it'll squeeze blood over to the right side through the hole, and then more blood goes to the lungs than what normally should. It results in pulmonary overload, and the heart has to work harder. And these patients, you'll hear a murmur because that blood is flowing through an abnormal hole. And you'll also see heart failure symptoms. And you're familiar with heart failure. You understand the signs and symptoms. With infants, we also want to watch for poor feeding because they basically get tuckered out while they're feeding because of the heart failure, and they need more breaks, so smaller, more frequent feedings. So watch for poor feeding, sweating, tachypnea, as well as other signs of heart failure that you've already learned. The second need to know defect for increased pulmonary blood flow or left to right shunting is patent ductus arteriosus. And if you remember, the ductus arteriosus is a temporary blood vessel in a fetus that connects the pulmonary artery to the aorta, and it basically allows blood to bypass undeveloped non-functional lungs, and that way the blood can flow directly to the body. So with patent ductus arteriosus, or PDA, blood is flowing from the aorta through a hole that didn't close into the pulmonary artery and then to the lungs again. So the lungs are getting too much blood again with PDA. You could hear a murmur, you could have bounding pulses and widened pulse pressure, but the big thing to remember with left to right shunting or increased pulmonary blood flow is that too much blood is going to the lungs. Next up is obstructive defects, and just like it sounds, we have blocked blood flow here with obstructive defects. Blood can't get out of the heart easily. The types of defects we'll talk about: pulmonary stenosis, aortic stenosis, and coarctation of the aorta. So with pulmonary stenosis, our first one here, we have a narrowed pulmonary valve. So right here we have a narrow pulmonary valve, and you can see the right ventricle doesn't usually look this big, right? It's really hypertrophied here. The muscle mass has really grown, and that's because the right side of the heart has worked so hard to push against this narrow pulmonary valve to get blood through that it's started to overdevelop. So the right ventricle really struggles to push blood into the lungs. The right-sided pressure increases and less blood is reaching the lungs. With aortic stenosis, it's the aortic valve that narrows. So the opening between the left ventricle and the aorta becomes smaller, and the left ventricle really struggles to push blood through that narrowed aortic valve and into the aorta. This results in decreased cardiac output, right? Because the left ventricle is responsible for pushing blood to the body. So you're going to have a decreased cardiac output and an increased risk for shock with that patient. Lastly, for an obstructive defect, we have coarctation of the aorta. And you see the aorta is a pretty big vessel. And if you have a coarctation, it's a narrowing of that big aorta. And blood can't flow as well to the lower body because of it. So what we'll see in these patients is high BP in the arms because the blood is able to go out to the arms above that obstructive site, and then low BP in the legs as well as weak femoral pulses. Next up, we have defects that decrease pulmonary blood flow. Our first one is tricuspid atresia. These types of defects cause right to left shunting. So with defects that decrease pulmonary blood flow, think the blood is bypassing the lungs. It goes to the body without any oxygen. So be watching for cyanosis. With tricuspid atresia, what's wrong? There's no tricuspid valve. So there's no flow from the right atrium to the right ventricle. You got your right atrium, no valve, nothing going on in the right ventricle, and baby relies on blood being rerouted through defects, so a hole through the septum here where blood can pass over to the left side of the heart. You're going to see decreased blood to the lungs in this patient as well as cyanosis. So because the blood doesn't take the normal path to the pulmonary artery because the valve is blocked, blood flows from the right atrium to the left side of the heart, with blood reaching the lungs only through abnormal holes, often requiring surgery to fix. Next up is tetralogy of Fallot. Think with tetra, think 4. So there's actually 4 problems going on here. We have ventricular septal defect. We have a hole between the septum of the ventricles. Pulmonary stenosis, which is thickening of that valve. Right ventricular hypertrophy, that buildup of that muscle there, as well as overriding aorta. And what overriding aorta means is normally the aorta is taking blood only from the left ventricle. And with overriding aorta, blood is coming in from both the right and left side of the heart into the aorta. With tetralogy of Fallot, blood is entering the aorta that hasn't been oxygenated yet. So the baby receives less oxygenated blood to the body. And signs and symptoms that you'll see with this patient include cyanosis, so just because of that decreased oxygen, as well as something known as TET spells, which are acute hypoxia episodes. TET spells are also known as hypercyanotic spells, and they're life-threatening episodes with severe cyanosis, so blue-tinted skin, lips, or nails, because of that reduced blood oxygen level. They can be triggered by stress, such as crying, feeding, or waking, and they occur when pulmonary blood flow drops, reducing oxygen to the body. Interventions for a TET spell are pretty specific. The primary intervention is placing the child in a knee to chest position, pushing the knees against the chest to increase blood pressure and push more blood towards the lungs. Long-term management usually involves surgical repair. We'll highlight some common interventions for congenital heart disease. So just interventions for these defects in general without talking about specifics for each case. Things you might see, medications. Prostaglandins can help keep the ductus arteriosus open. Sometimes that opening is necessary in order for some blood to reach the lungs to get oxygenated. So the patient might be on a medication to help keep it open until the repair is done. Diuretics, which you already know from heart issues, heart failure issues, to reduce fluid overload. And digoxin, which is a common medication with heart failure. Again, you're probably already aware of it with your adult medic patients. One key thing here with digoxin, we know that digoxin will slow the heart rate and make that pump more effective. It's a positive inotropic medication. But usually with adults, we hold digoxin if a pulse is less than 60. For children and infants, the guidance can vary a little bit, but with older children, we want to hold if the apical pulse is less than 70, and with infants, we want to hold the digoxin if the apical pulse is less than 100. Some references will say 90, so 90 to 100 will hold the digoxin because we know it's going to make that heart rate even slower, and we don't want to cause any issues. Other treatments that can occur for these heart defects include cardiac catheterization to help identify the problems, and then surgical repairs, whether it's patching up holes or repairing problematic valves. Priorities for the nurse when dealing with pediatrics with these defects include monitoring oxygenation, assessing feeding tolerance, watching for heart failure, and making sure that parents and caregivers understand the diagnosis, understand the meds that are prescribed, and understand any sort of procedures that they might have already been told about from the provider and have scheduled.